Okay, so welcome to this late afternoon session on unicompartmental knee replacements. For all of us who are in Hall B today, there is good evidence that UKRs work as a philosophy, and despite this evidence, we see that a lot of surgeons are reluctant to adopt the philosophy. Hopefully, at the end of this session, midway through it, we convert a few to try and understand that if this surgery is done well, then it can have very gratifying results. I'm Dr. Miten Sheth, and I have Dr. Amyn Rajani as my convener for the session with me as well. I invite Dr. Amyn. I think the stairs are on that side. And then we have 4 lectures for you, followed by a case-based panel discussion, and hopefully we can solve a lot of doubts or give you the enough tips and tricks for this procedure. Dr. Amyn.
Good afternoon, everybody. This session is planned in such a way that most of us will start incorporating UKR into our arthroplasty practice. We want more and more people to do this because it has got excellent outcomes if done correctly. Hopefully with this series of lectures and panel discussion, a lot of doubts will be cleared. And we've got a stellar faculty with us, starting with Dr. Abhishek Nerurkar. He's been doing a lot of Oxford partial knee replacements. We also have, please come up on stage as I call your name. We have Dr. Miten Sheth, who was just here. He's been doing a lot of mobile bearing knees as well. We have Dr. Ashit Shah, who does mobile bearing as well as fixed bearing knees. And we have Dr. Adarsh from Hyderabad. He's a pioneer in robotic surgeries. He does robotic total knee replacements as well as partial knee replacements. And yours truly, I'll be talking about a lot of cases, 4 cases, and we'll have a lot of discussion and audience participation. Thank you so much. May we ask the first speaker to come on stage and start?
So, good evening, everybody. In next 6 minutes, I'm going to talk to you about why you should consider doing unicompartmental knee replacements. So, there is a general, notion in between the orthopedic surgeons that UKR is a sham surgery and it fails. It always fails. And then why should I consider doing a UKR if I have to go ahead and do a TKR for the same patient? To be really honest, even 4 to 5 years back, even I used to feel the same. And then I saw some results and then I realized that, no, I need to think over it. This is not the right thing. UKR does have good results. So I was fortunate enough to go and attend the Oxford knee course. And then I started doing UKRs and I have never regretted even once after I started doing UKRs. So there are a lot of times you'll see patients coming to your clinic with pain which is not being managed on conservative treatment, and you have seen the X-ray, you'll see that it's a single compartment arthritis, the other parts of the knee are relatively intact. You don't want to operate, but then ultimately the patient is not getting relieved and you plan to go ahead with the surgery. You open the knee and you see something like this where there is only a single compartment which is intact, which is affected. The other part of knee, the ligaments, everything is perfectly intact. And then you feel bad, there was no option but to go ahead with the knee replacement. These are the ideal candidates. This is anteromedial OA, and these are the ideal candidates for UKR. You should actually go and offer them UKRs. Only replace the damaged part and retain all the structures that are normal and intact. There are multiple benefits with UKR. It is biomechanically much superior to the TKR. Once you restore the tension in between the ligaments, the biomechanics start functioning like a normal knee, and you get something like a forgotten knee. Nowadays, we are trying to achieve kinematic alignment even for total knee replacements and high tibial osteotomies. We have realized that we should not overcorrect them, and in UKR, you get exactly that. You get kinematic alignment. So it is comparable to the natural knee, which is normal for that patient, not the normal for the X-ray. If you are taking good cuts as per the manuals, then there is a preservation of bone stock. This is a prime property which you can use anytime if the patient requires future surgeries. It is more anatomical, lesser morbidity. What it actually translates it into is a natural feeling of the knee joint. Since you have your intact and functional ACL, you get a good proprioception. Patients actually don't realize that the knee has been operated in most of the cases. There is high index of satisfactions. low requirement of rehab. So most of the patients will do 90 to 100 degrees very easily on day 2. And when they come to you for suture removals, they will have almost full range of movement without any extensive rehab. Faster recovery and return to function is also very, it's better as compared to the TKR. And they can do stair climbing, stair descent. Most of the things they do on their own. You don't need to train them. What about 10-year survival? If you compare to TKR, so this study is from basically the designer group and 1,000 cases showing 96% of 10-year survival in Oxford, 3 UKRs. Okay, some may feel though, okay, this is designer series, the results may be biased. And, the results may be biased and there may be concern regarding whether you and me can give similar results in our patients or not. But these are multicentric studies which also show different parts of the world. If you are doing significant amount of work converted into your UKR, then the results are hovering. So the 10-year survivals are hovering around 90% or more. So yes, if you train yourselves properly, you can do it and get good long-term outcomes. There are several other advantages of UKR: smaller incision, reduced blood loss, lesser infection rates, less risk of transfusion, shorter hospital stay. So nowadays, they are tending towards trying to get a daycare UKR surgeries, lesser readmission rates. Again, multiple papers which will show you that you get better restoration of the physiological gait pattern. Patient-reported outcomes are superior to the total knee replacements, and forgotten knee scores are better. As compared to the total knee replacement, registry data shows that there are lesser incidence of thromboembolism, infection, stroke, myocardial infarction, and even mortality. So complication-wise, it is much superior to TKR. However, the revision rates in all the registries have been around 2 to 3%, 2 to 3 times higher than that for TKR. And there's a solution for that, I'll tell you. So basically, how to minimize the revision rates? You have to incorporate at least 1/5 of your arthroplasties into UKRs. So if you are doing 20% of your arthroplasties as UKR, then you will be able to reproduce your results and you will be able to reduce the failures. When to do, Dr. Miten will talk about it, but you should do it only in anteromedial OA with functional cruciates. Wherever there is contracture or superficial MCL, you should not be doing it. And this is determined on the valgus stress views. Certain myths I wanted to clear out. If you have mild patellofemoral or lateral compartment arthritis, you can actually go ahead and do it. Age is not a barrier. BMI again is not a barrier. And physical activities, if I think, it's better if you do a UKR in patients who have higher physical activities. True contraindications, only inflammatory arthropathy and when the ligament function is compromised. Last thing is surgeon factors. Training is absolutely important. You have to train yourself before going ahead for the UKRs. Otherwise, it's a recipe for failure. You should know what can go wrong and prevent the complications because there's no U-turn. You can't come back once you have done any complication. The learning curve is steep, zero margin for error, and that is why you have to reproduce the same results in each and every case. And lack of peer backup. Suppose if you are doing something wrong, you may be in for a shock because your peers may not back you up. Communication is absolutely very important before you plan this surgery. So in short, UK is an excellent procedure. Patient selection is extremely important. Do not discard the surgery considering that, this is going to fail. If you do it in a proper patient, you are bound to get good results. And forgotten knees, that is very difficult to get on TKRs. You have to stick to the manuals to get the best outcomes. There is no my way of doing the surgery. Follow the manuals and you will get good results. No margin for trial and errors. Thank you.
Abhishek, thank you very much. I have one question for you. Abhishek, when you did your first UKR, there are a lot of people who do Oxford courses and training, but they're very scared to start off. Would you have some advice for the youngsters to how do you do their first case and get confidence?
I think, it's everybody, once we start doing UKRs, there is fear in our mind as if what is going to happen to this particular patient, whether this patient is going to survive the knee or not, what will happen if I complicate, what if this patient goes out and shows somebody else about, if something goes wrong. So these are there, but I reassure you have to basically understand the concept. You have to first believe that that this is a good surgery, believe in what you're going to do, and follow all the steps correctly. It's all written in the manual. You have to learn and follow all the steps correctly as per the manual. Don't think that I'm going to experiment or I'm smarter than the instrumentation. If you do everything right, I think there's no reason why you should hold back.
Thank you so much. Miten, can we have the second talk, please?
So we had our mentors in Hall A talking about painful, non-infective joints, and a lot of UKRs were discussed. But Dr. Nilensha sir is here. I think what they pushed through was patient selection is the key. If you go wrong with selecting the wrong patient itself, that's just the beginning of all the problems. Now, assuming you know the surgical procedure well, or you're going to conduct it well, the step before that is picking the right patient, picking the right knee. Step 1 to that is have no bias. So there's a surgeon bias here. Many surgeons at the beginning of their practice, midway through it, towards the end of their careers as well, are just biased towards the total knee replacement because they know that they can do it better, they can do it consistently. But if you want to evolve as a better surgeon of the knee joint, then you should be offering to replace only those parts of the knee that are completely worn out and to protect those parts of the knee that are intact. So get that bias out, and if only a single compartment of the knee joint has been worn beyond repair, then replace only that. Second, there's a patient and relative bias. Many times in our OPD, we have patients coming to us and then asking us, हमको total knee replacement ही चाहिए because partial knee replacement दूसरे डॉक्टर ने बोला है फेल हो जाता है बहुत जल्दी. You have to be careful of those patients who have a bias against a UKR. If you still go on and insist and do a partial knee replacement for such patients, you may have problems at the 3-month, 6-month and 9-month follow-up where they still have in their mind, they have a bias against the surgery right from the beginning. Both of these can be solved in part by evidence. From the surgeon's side, you read more and you try and understand that if this surgery is done better, then it can work. And second, if you have colleagues who publish something nice, then you can actually have a printout and give it to the patient that's understandable, so the patient also understands that the surgery is backed by evidence. Last is a practice bias. You shouldn't have that as well. Many a times, people practice in areas where they don't have access to a partial knee, or they have access to a partial knee, but nobody is able to supply a total knee replacement as a backup. Somehow you need to solve that problem. Every time you do a uni, you should have a total as a backup in all cases. So the steps are very simple. This is like a didactic lecture, but first, confirm that it's bone-on-bone medial compartment or lateral compartment or patellofemoral arthritis. If it's not bone-on-bone, then there is good evidence to say that a high tibial osteotomy may work better in earlier, lesser grades of arthritis. UKRs don't do well if done on grade 2 and 3 medial compartment or lateral compartment knees. They do much better when there's bone-on-bone arthritis. HTOs don't do well for bone-on-bone arthritis. Next, having said that, if it's bone-on-bone arthritis, you should have a symptomatic patient. The patient should be complaining and all the complaints should be pertinent to that particular part of the knee. 2, rule out inflammatory arthritis. So if all of these markers are negative and you're sure that this does not exist, only then you can be sure that the other compartments of the knee are unaffected. If you see an X-ray like that, I don't know if you can make out the yellow arrow is alluding to chondrocalcinosis or a calcified meniscus, and that shouldn't scare you or prevent you from offering a partial knee replacement, but any other inflammatory markers positive are a definite contraindication. Third, isolate the location of arthritis. How do you do that? So you may need a Rosenberg view or a PA view in flexion to confirm that it's bone on bone. What's the difference between the first X-ray and the second X-ray? The second X-ray is a plain AP, but you can see slight lateral subluxation of the tibia. If there is subluxation, don't worry. The next step to do is to get a to get a valgus stress X-ray. If you do a valgus stress X-ray, there are 2 things that you can confirm. One, that the lateral compartment is not closing. If it's not closing, there's more than 5 mm opening even after a valgus stress, it means that the lateral compartment cartilage is intact, it's good. And most of the lateral tibial subluxation many a times reduces on the valgus stress. So you have now isolated the location of arthritis to the medial compartment. Next, you do a skyline view. And on the second one, on the top first row, second image, that's just an osteophyte. A good skyline view is a 1/3, 2/3 that you can see in some of these skylines, not in all. But like the third one in the first row is the only one that should actually scare you from offering a uni, and that's a grade 4 bone-on-bone lateral patellofemoral joint arthritis. Next, confirm intact cruciates. How do you confirm an intact cruciate? Keep seeing a lot of lateral knee x-rays. A simple lateral knee x-ray seen again and again will make you differentiate between anteromedial wear and posteromedial wear. If there is wear on the posteromedial aspect of the tibial plateau, it's an indirect marker that the ACL is not functioning. And for mobile bearing knees especially, it's important that the ACL function well. If I, for example, use a robotics platform with a fixed bearing uni, so I can do a uni even in an absent ACL, but I reduce the tibial slope to compensate for the no ACL. Confirm intact collaterals. So cruciates are good, now the collaterals need to be good. Correctability of the varus is more important than the degree of varus. If it's a fixed varus, the MCL is contracted, maybe it's not that great an indication because your kinematics over the extension to flexion range will change. And lateral opening warrants attention, that means there is PLC opening. Second last, isolate the location of deformity. So if there is extra articular deformity in the metaphysis or the diaphysis, then you start thinking whether you still want to place the uni and accept the kinematic alignment. And we use this CPAC classification to just make sure that we are noting joint lines as well. And you want to try and keep the joint line obliquity. Can an MRI help? Just 3 things. It can help to judge extra bone marrow edema, ACL mucoid or ganglion cyst, which will change your flexion extension, and then sometimes you have a discoid lateral meniscus. Counsel for survivorship in these 3 points: high activity level, BMI, and younger age. You can still go ahead and do it, but it may have, there is some evidence to say it may affect survivorship. Obviously, you make sure that the problem is not coming from the spine and the hip. So in summary, confirm a bone-on-bone medial compartment arthritis, rule out inflammatory arthritis, make sure the location of your problem is right, cruciates and collaterals need to be intact, and MRI and survivorship counseling specific cohorts. Thank you.
Thank you, Dr. Miten. As Dr. Ashit Shah loads his presentation, I have one question for you. When do you decide to do an MRI for the patient?
Only for three things. Mostly for 2 things. One, if I'm offering the uni to a patient with a 5 or 10 degree of a flexion deformity and flexion restriction range, ideally I would like to offer a uni to a patient who's able to sit down cross-legged very comfortably and has full range, 150. If there's restriction of range, I want to check if the ACL is mucoid or has ganglion cyst or something that's going to affect my outcome, and a severely painful pre-op where I suspect maybe there's something going wrong, osteonecrosis or medial tibial bone marrow edema, that I'd go on and do the uni, and then in my early first or 1 or 2 months, there's too much pretibial pain. So the MRI would allow me to counsel better.
Thank you so much, Miten.
Right. Good evening, friends. Thank you, WIROC, for this opportunity. Now we've got the technology, we've understood, UKR works well, we've got an ideal patient. Now as a surgeon, you need to decide which particular implant you need to use. We have on our platter a fixed bearing UKR implant, which is a modular tibial tray design, or we have a monoblock, which is either all polyethylene tibia or a molded metal back. Mobile bearing has a modular poly insert, not fixed to the tibial component, and many centers around the world actually prefer this particular implant, including quite a few speakers before me. So fixed bearing articulation, it is an anatomic femoral component with a flat non-congruent polyethylene insert fixed to the tibial base plate. As we can see here, the contact point moves back and forth with flexion and extension of the knee. High wear rate of the poly in the early design of this FB processes, fixed bearing processes, was questionable. However, the latest techniques of manufacturing of poly, surgical technique improvement, and obviously our experience has improved the outcome of these fixed bearing knees. What happens in mobile bearing is highly conforming articulation is a single radius femoral component, so it's almost like a sphere with a congruent mobile poly insert. So that has got maximum articulation between the femoral component and the poly. The poly moves back and forth with flexion and extension, and the movement occurs at both the interfaces between the femoral component and the poly, and between the poly and the tibial insert. Here are the biomechanical comparison of fixed versus a poly, and it shows the point loading that happens in the fixed bearing on the slide on the left and the mobile bearing on the extreme right corner. So with all this, we looked at the literature and meta-analysis, May 2002 publication, 22 publication from Nicola Maffoli group. They compared fixed versus mobile, and there were no difference in the range of movement, knee scoring system, Oxford knee score, rate of revision, aseptic loosening. So there was no superiority of mobile bearing over the fixed bearing. Another meta-analysis showed there is no difference. However, they picked up the modes of failure in mobile versus fixed. In mobile, it is the bearing dislocation that happens, and it's an early failure. However, in fixed bearing, it's a polywear, which is a late failure. Another meta-analysis, whose author is Dr. Hemant Pandit also, who is from the Oxford group, and they categorically mentioned revision rate for mobile bearing is slightly higher as compared to fixed bearing. And revision rate of mobile bearing, if done in a lateral compartment, is 4 times higher than fixed bearing. Overall, fixed bearing survivorship is slightly better than mobile bearing, and this paper is coming from UK. So that's the motherland of mobile bearing knee replacement designs. Modes of failure, fixed bearing versus mobile bearing, aseptic loosening and polywear, which is late in fixed bearing, and in mobile bearing, it's a bearing dislocation. As we saw in the x-rays, which is lower down there is progression of osteoarthritis in the lateral compartment. And this patient is not right because there is something wrong with the femoral component, and this is what was discussed in the previous session, just we heard in Hall A. To improve wear pattern in fixed bearing, there are a lot of things that are done. Cobalt, chromium, metal less than 0.05 nickel, polyethylene changes moderately cross-linked, irradiate to 5 millirad, and most important thing is the surgical technique improvement. Gap balancing, slight undercorrection, and restoration of the constitutional axis. Use of technology, navigation, and robotics have definitely helped us improve our wear characteristics. Technical issues like increasing the posterior slope of the tibia helps reduce the wear as well. So in mobile bearing, the problem is polydislocation. And as we see in these 2 x-rays, the first one is 8 months post-op. The second one is a couple of years after surgery. It's a fracture of the poly and then dislocation of the poly insert. Why does the poly dislocate? Either there is malalignment at the index surgery, there is impingement of the osteophytes or cementophytes as we call it, improper soft tissue handling like injuring deep MCL with the saw or with the retractor, which is not identified at the time of surgery. As we see in these 2 cases, this case is the right side, probably the positioning of the implant is not right and has caused the poly to gradually subluxate medially. The left side, where it is properly done, both the x-rays are about 7 months apart. Left side, she is asymptomatic. In mobile bearing, improper balancing. So if a mobile bearing is undercorrected, tightening of the medial side increases the chance of bearing subluxation and dislocation. If it is overcorrected, we've seen contralateral compartment gets affected. So there is a progression of OA. So difficult to obtain an optimum balance in a mobile bearing without the use of advanced technology. And inappropriate cut leaves some space between the implant and the bone, causing further aseptic loosening. Fixed bearing, however, fails late due to wear. So what are our strategies? If fixed bearing is slightly undercorrected, it prevents loading of the contralateral compartment straight away, so that progression of the lateral OA is prevented. It loads the medial compartment. However, the bearing cannot dislocate because it's a fixed bearing. It restores the constitutional alignment of the knee, and improved wear properties of poly reduces annual wear rate of the polyethylene. So fixed bearing advantages are shorter learning curve. It can be done in functionally stable ACL deficiency, isolated lateral compartment OA. Modern implants with better wear properties have definitely improved our statistics. Use of robotics definitely can certainly reduce this disadvantages. Mobile bearing advantages, highly conformed design, superior wear property, better kinematics, better range of movements. However, the major disadvantages of mobile bearing are bearing dislocation, progression to the contralateral part, cannot be done in functionally ACL deficient knee, very high dislocation rate in lateral compartment OA, steep and longer learning curve. Also, positioning during surgery, fixed bearing is just like a TKR positioning. So just in case if you need to convert that into a TKR, becomes very easy. While mobile bearing is in a hanging leg position, and God forbid, if you were to do a TKR in this position, it is very difficult. You have to reposition, re-drape the whole patient. So surgical tips, just last 2 slides, please, Amyn. Tibial cut must be perfect. A single cut 4 millimeter deep from the anteromedial osteoarthritis defect on the tibia. Tibial preparation with care, sizing and positioning of the implant. A reciprocating saw must be used with care in the particular manner. As we see here, the final preparation of the tibial side, the saw has to be parallel to your tibial plate and should not lift the hand, otherwise it can perforate the posterior cortex. An ideal technique or any new device is good if it is easy to perform, it has got shorter learning curve, it is reproducible in non-designer surgeon's hand, and relatively low complication rate in average surgeon's hand. So why fixed bearing works well in my hand is the results of mobile bearing and fixed bearing are same as we've seen. The complication rate, bearing spin out and progression of lateral compartment OA is lower in fixed bearing, shorter learning curve, polywear and aseptic loosening in fixed bearing now at acceptable rate, and robotic technology definitely is going to help us getting our disadvantages of fixed bearing even low. So our results will be much better with robotic technology. As we can see in this lady, she can do this posture at least 15-20 times in a day. This 6 years post-op, post fixed bearing UKR. This is another lady, mid-term follow-up, bilateral medial UKR done, and she is able to do most of her activity very well. So I thank you very much for your attention, and if there are any questions, I'm happy to answer.
So we'll take the questions together at the end. I'd request Adarsh to take over.
Very good evening. I'd like to thank Dr. Amyn and WIROC for inviting me today. So I do Oxfords in my conventional cases, and I do a fixed bearings in my robotic cases. So I'm talking about the role of robotics in Unicondylar. When we think about robotics, we think about Chitty, we talk about Rajani, but our robot doesn't look so sexy. This is what our robot looks like. I'm speaking specifically about the Stryker Mako robot. The first question you may ask is, does it do everything? Like how Rajinikanth does in the movie, does it just deliver the baby for you? No. It assists us. We are still doing the surgery. It's going to give us a higher rate of accuracy and prevent any damage to the surrounding tissues. So this brings us to the classification. There are boundary control robots like the Navio and the Cori, and I think Dr. Miten is using it. Semi-autonomous is like the Mako. We are still doing the surgery, but it prevents us from going out of the haptic boundaries. And the fully autonomous, like the Merrill robot, which has come up recently. So just a brief look at the other robots. That's the Cori, that's the Navio, and this is the Merrill, which is doing the whole thing on its own. So this is a Mako. As I said, I'm still doing the surgery myself. This is, of course, a TKR. And you're cutting the bones within the haptic boundaries. It's bringing you to that plane, but not letting you go outside the plane. But the control is still in my hand. So the advantage of a Mako is I can do all the three with this, a total knee, partial knee, and a total hip. But what's the need? The first thing is we need to know that there is really a high incidence of AMOA in our patients, which we really are under-diagnosing. AMOA can be managed with uni and total knee. Of course, uni shows faster, as you see in Dr. Abhishek's talk, there are a lot of advantages of uni over TKR. And our study we did recently, which we published, has shown a staggering almost 46% of our TKR patients would have probably underwent a uni. We did a case study where we took photos of the intraoperative findings, and we saw almost 45% would have been unis. But still TKR is more popular because there's an increased risk of revision after uni. At least that's the thought process. Outcomes in uni, you've seen the studies showing more than 98-95% survivorship. Again, Dr. Abhishek has alluded to this. But why are the revision rates so high? Probably, of course, we all know it's a demanding procedure with restricted field of vision. Threshold for revision of unis is definitely less. So if a uni patient comes with pain, you're more likely to revise it than if a TKR patient comes. The potential for technical errors is very high. Poorly implanted uni may fail earlier. So it boils down to three things. A successful clinical outcomes of a uni depends on accurate component positioning, soft tissue balancing, and overall limb alignment, which is really not easy. There's too many calculations to be made. So what if we have some technology which can tackle all these three and give you reproducible results every single time? So that's the robotic assisted partial knee replacement. We call it RAPCA. Okay, so as I said, PKR is technically demanding and a slick surgery. Robotics prevents overstuffing of the opposite side, which is very important. We don't want it to lead to lateral arthritis. So I feel robotics and partial knee is probably the future. If robotic does have any value, I would say it's in partial knee more than anything else. And the three core features which is going to give us those outcomes are these things, in the Mako especially, the enhanced planning, dynamic joint balancing, and the haptic guidance. Enhanced planning, basically we're taking a CT scan, you take multiple slices, they're all spliced together, and we get a 3D model of the patient's knee. And this is going to help us in implant sizing and alignment to bone anatomy beforehand itself. So your alignment and your sizing is done before we even start the case. You've done all your planning beforehand. Of OT layout, just a brief thing. The robot comes in on the ipsilateral side. There is a screen and a camera on the other side. Then we have to do a bone registration where you're feeding to the robot the actual points in real time to make sure that it's matching with the CT scan. This is a fail-proof mechanism to make sure once you're trusting the robot, you can trust it blindly. Only if you are within 0.5 millimeters of accuracy of the CT scan will the robot allow you to go ahead. Then, of course, there's dynamic joint balancing. For the ligament tension part, you're going to capture the leg in various positions in the corrected pose. So you're going to say that this is what I'm going to try to get in terms of MCL tautness and in terms of alignment of the limb. After you do that, you get this graph. Anything above the line is loose in that particular position, like 10 degrees, 45 degrees, 90, and 120. We want to aim for around 1 to 1.5 mm loose in all the 4 captures. So let's say if you have a bar below the line, which is tight, you have you just move around your implants up or down, flex it a bit more. There's a graph for this to help you get to your whatever you want in terms of tautness of the medial compartment. So you're going to prevent overstuffing. Then you have cartilage mapping. It helps to create a smooth transition from the femoral component to the cartilage, so there's no jump for the patella. You can also check your implant tracking to make sure there's no edge loading. Your femur and tibia should be, all your post captures should be centrally aligned over each other. Of course, bony preparation is done by burring. In the new technology, half of it is done by saw and half of it by burr. As you can see, it's not going to allow me to go outside my haptic boundaries. So this is the step which is addition over the navigation, the actual burring part. Then you put in your trials, you can check your kinematic evaluation, put your knee through the range of motion, and you check your limb alignment, joint gaps, and range of motion. And of course, cementation and final implantation. And the best part of this is 100% reproducibility of your post-op x-rays. Every x-ray is going to look like this. You can also do other compartment unis, lateral unis, the patellofemoral. We haven't been doing many of them yet. I'm sure in India it still hasn't caught on, but it will happen soon. What about the procedure time? You may think that all the registration may take longer, but right now we're not only neutral, but even faster. 35 to 40 minutes, we're usually done. What does it mean for the patient? Yes, the surgeon is having a better time, but here you have reduced surgical time and blood loss, unparalleled accuracy, smaller incisions, less pain, and faster recovery. Less pain in the 90-day period, 92% satisfaction at 2 years, less of everything, less bone tissue damage, less analgesics, less time to hospital discharge. And if you compare the manual versus robotic, manual are the gray, robotic is the yellow, just 2-3 more slides. You can see the accuracy in all the 6 planes, that is femur, sagittal, femoral coronal, femur axial, and the others as well in tibia, all higher in the Mako in terms of positioning. Radiological outliers are much less in the RAPCA versus conventional. And again, I already mentioned about the pain and everything. Gait comparison, there is no difference between healthy knee and a RAPCA knee. That's what is found by this paper in 2018. And the learning curve, the learning curve of a Mako has a shorter learning curve than a conventional uni because Oxfords are really difficult to do. All this literature is for the Mako, which I'm speaking about. Our outcomes, just quickly, this is day 2, the day after surgery. This woman is walking, she's sitting on the floor and talking to us, and this is where we were sold on robotic unis. This is an elderly gentleman a week after surgery, and this man said he wanted to play golf again, and he sent me this video just a month after surgery. And he's doing absolutely fine. Why are we getting better results? Probably because of better internal homeostasis, haptic control, and no overstuffing of the joint. We're doing a study now comparing our robotic versus conventional partial knees. I think this paper should be ready by mid next year, and let's see what the results are going to look like. Thank you so much.
Just one question there. When would you allow a patient to have a pivot like while playing golf post your surgery? If they ask you that question electively. Just
the first follow-up after a month, I'm really not bothered if he does pivot after that. I'm okay with it. because his ACLs are intact, everything is fine. If I'm confident about the post-op implantation, I don't have a problem with it.
We'll go ahead with the case-based discussion. Dr. Amyn Rajani to take over.
Thank you, Miten. I'm going to be presenting 4 cases. We're going to be opening the questions to the panel, and audience is free to ask questions during this session and after. I've compiled 4 cases, 2 are simple cases for the audience to understand what to do and what not to, and 2 are complex cases which we will cover as well. This is an 80-year-old active doctor with pain in both knees since a few years. He's unable to go for his regular walk since a year. No medical comorbidities. There is medial joint line tenderness, clinically correctable varus deformity. The range of motion is 0 to 120. Anterior drawer test is negative. I'd like to ask Dr. Ashit Shah, what would you do for this patient, sir? Okay, these are the x-rays. We have the AP standing, the scanogram, and the lateral views.
If you see the criteria of unicompartment knee replacement, Cousin and Scott, they describe the original criteria. However, if you do those criteria, only about 10% of the patients will fit into the bill. If you apply the extended criteria, this patient fitted into most of them, but I need to see a skyline and I need to see a valgus stress of the affected knee.
There you are, sir. You have a Rosenberg, a valgus stress view, and the skyline view.
Right. So this is something that we have to do when you are planning a uni. You need to have this set of X-rays, weight-bearing AP or PA, Rosenberg, depending on the amount of medial compartment osteoarthritis. A proper lateral. A lateral has to be proper because both the condyles have to overlap on each other. Valgus stress, as we can see here, and a skyline view. So it's the left knee that is more painful, right?
Will you go ahead with the partial knee for this patient, sir?
Yeah, so I know your concern is only his 80 years of age. There is actually no evidence that if you do partial knee, they are going to fail here because, osteoporosis probably does not, come into the picture. In fact, if you do this surgery for someone who is 80 plus, just tell them that this is the best surgery you can have for the rest of your life. For a younger patient, the only surgery you will have for the rest of your life, because it is likely to last you for 10 to 12 years if done properly.
Okay. Miten, what would you do? Would you also go ahead with a partial knee in this patient?
I would. I'm only surprised. Why is the range of motion only 0 to 120? Is the patient overweight? Because I expect...
He's not overweight, but he was terminally painful. So we did not push him, and we just calculated the ranges based on his active flexion.
Yeah. So I would plan for a partial knee with a total knee standby.
What about you, Abhishek?
So in this case, because of his, since he's 80 years old, I would actually plan for a partial knee with a backup of total knee. But I would be a little concerned if this patient was little younger. I mean, 55, 60s, I would be a little concerned because...
So we'll be going to that, the younger patient in the next case.
But at 80, I would go ahead with the partial knee for this patient.
Okay. Nobody for conservative management thinking that he's 80 years old, why go ahead and do a surgery in the first place?
Unless the patient and relatives are hell-bent on not getting operated.
So my criteria is the patient has come to me for pain. He wants, he's not able to do his regular activity which he likes. And I have to offer him a solution. Conservative management is not going to offer that. And we don't know how long this patient is going to live. He may live for another 10 years, and we don't want him to be painful. If you look at the, this is what we did. This is, you look at the lateral condyle, it's pristine. There is absolutely no evidence of any changes in the cartilage on the lateral side on both knees. We went ahead and did a bilateral partial knee replacement for this patient. And we've done literature review which shows that unicompartmental knee in arthroplasty in patients older than 75 shows excellent outcomes. There is no role of any revision post. In fact, they do much better than the younger patients. And we have this for both the fixed bearing as well as the Oxford group.
Can I make a comment here?
Yes, absolutely.
So at Sunshine, we have a bimodal distribution of our patients. And as you said, 100% anybody above 70, if they have an X-ray like that, I'll just blindly tell them to go for uni. I'll convince them.
Absolutely.
But also younger patients, around 40 years also with AMOA, we're happy to give them a uni because when they come for revision, always easy to convert to a primary TKR.
Absolutely.
So
Absolutely.
for younger patients, it is the first best operation. For older patient, it is the first and the only best operation.
So the message here is that age is not the criteria whether to decide whether you want to go ahead with a total knee or a partial knee. It is the bone on the medial side and the intact cruciates which would determine whether we want to go ahead with a unicompartmental knee or not. This is the second patient, a 55-year-old female with pain in both knees since few years. Pain in the left knee is more severe than the right, unable to do daily activities, correctable varus on both sides, range of motion is terminally painful, severe medial joint line tenderness, no lateral tenderness, anti-Radroa test negative. These are the x-rays. Looking at these x-rays and the age, I would want the panel, Adarsh, what would you go ahead and do for this patient?
You said she's 55?
Yes, that's correct.
This definitely looks like, as Dr. Miten put it, there's a slight kiss there. It's almost like a peck rather than a kiss.
Right.
So I don't mind giving a varus stress view just to check whether it's really closing or not. But if that is giving bone on bone, I'd blindly go for a uni for this case.
Okay, so we have a Rosenberg view for you, the bilateral Rosenberg view, which shows bone on the medial side.
Yeah.
Would you go ahead and do a partial knee for
I would do a partial for this.
What about you, sir? Ashit, sir? Dr. Ashit?
Yeah. So now we have all these x-rays. Now the understanding of a valgus stress x-ray is really important because we need to see two things which were seen on this valgus stress x-ray. If you can just go back to that slide, is first of all is that where is the valgus stress?
We are going to be showing the valgus stress x-ray. Why would you want to do a valgus stress x-ray, sir?
So that's the most important x-ray that I want to see in this before I put the patient on for a uni, because number one, it shows that a lateral compartment has not compressed. Number two, the lateral tibial spine is not kissing the femoral condyle. It means there is no ulcer on the lateral femoral condyle and the ACL is intact. And the part subluxation that you can see on this weight-bearing X-ray gets reduced on that valgus stress.
So earlier there was this concept that we do valgus x-rays to see if the medial joint is opening or not. But that is not the only reason why we do valgus x-rays. We do valgus x-rays to see whether the medial joint is opening without collapsing of the lateral compartment. So have a look at this X-ray. This is a weight-bearing X-ray showing lateral compartment is absolutely normal on an AP weight-bearing X-ray. But having a look at the valgus stress, you can see that it's completely collapsed. And I would definitely not go ahead and do a partial knee replacement in this patient. Within what other option do we have in a 55-year-old patient? Would you do an HTO? Would you conserve this patient? Would you?
I'd still go ahead and counsel the patient that I'm going to go in for a partial knee. I do fixed bearing unis using the robotics platform. I'm going to open the knee up and look at your lateral side. And if I find it pristine, then I'll go ahead with a partial knee. If not, then I'll try and retain in my head, I know that I'll try and retain the PCL and do a cruciate retaining total knee.
Abhishek, what do you feel? You change your decision of doing a partial knee?
I think this is little on the dicier side. I would actually, although it's not mentioned, to do a MRI, but I would prefer to do a MRI in this patient to understand more about what is happening.
So I have not put up the MRI finding here, but we had done an MRI for this patient which showed pristine lateral compartment. Adarsh, what would you do now?
Yeah, so you said there was a collapse. Maybe very slightly, I won't consider this as a complete collapse. I've seen cases where they're like almost touching on the lateral compartment. As Dr. Abhishek said, I would probably be on the fence. Still don't do an MRI.
What about laterals? What about the left side? You'd still...
left side, yes. I was talking about the right. I thought we're talking about the right.
No,
left,
I'm talking about both the knees, sir.
Left also, it's not a complete collapse. I would still go for a uni with a backup option for TK.
Anybody going for a total knee in this patient?
Last resort.
I think so. This is still fits into the criteria of uni, because if you have, even on the left side, let's talk about the left side. If you have slight collapse of the lateral side, however, if her ACL is intact, which we can see from here, and from the lateral X-ray that you showed, that there is a good cartilage posteriorly on the medial condyle. So this fits into anteromedial osteoarthritis, because this collapse also depends on the person who's going with the valgus stress. If it's very strong and really giving a good pull, it probably might just collapse.
Yeah, but it shouldn't. The joint space shouldn't go down, even if no matter what the force applied is. Adarsh, I wanted to ask you.
I just wanted to make a point.
Have you ever? Yeah.
Yeah. See, we can see the valgus stress views, obviously. Have you done this supervised? I assume.
Yes,
But,
they are.
but you know what? Sometimes, because of the angle of the X-ray, you may get a view like this, which is quite possible.
Okay, I want to ask any of the panel, Adarsh, when you've done it, if you happen to do an MRI of a patient similar to this, and you've seen that the MRI shows that the lateral compartment is pristine, and when you've opened the joint, and you've seen there are cartilage lesions at the weight-bearing portion, have you ever encountered something like this?
So firstly, I've never done an MRI for a uni patient, but I have gone into cases thinking this is 100% uni and opening and seeing there are a few ulcers. Just if there is a big enough ulcer and it's in the weight-bearing, I would not hesitate to convert it to UKR. I have a low threshold to convert because we do, already people are biased against it, so you don't want to take extended risks.
So I'll tell you what we did. We went ahead and did a total knee for this patient. The reason being that when we opened the joint, first on the left side, we realized that there are lesions on the cartilage on the lateral side. And we went ahead and did a bilateral total knee replacement for this patient because I didn't want to do a uni on one side and a total knee on the other side. Although we've done that in the past, but I didn't want to do it for this particular patient, and she's doing absolutely fine. I know she's going to come for revision 15 to 20 years down the line, but that's okay. I won't be practicing at that time.
So here, can we define a role of MRI in UKR? The more number of MRIs you do, the lesser number of the UKRs you will do.
Yeah, I'm going to go to the next, and then we can open the discussion if we have time for the audience. 58-year-old obese female with pain in both knees since a few years. Again, classical medial joint tenderness. She has rest pain and stiffness as well. BMI is 35. Range of motion is terminally painful. These are the X-rays, AP standing and lateral. These are the valgus X-rays, the Rosenberg view, the scanogram. This is the MRI which shows mucoid degeneration on both the sides. What is the treatment of choice? Adarsh?
Again, for me, it's a functional ACL is more important than how it looks. So again, I'll plan for a uni. I'll go in, check with the ACL hook or any instrument, whether it's functional. If it's fine, I'll go ahead with the uni.
Due to lack of time, I just want a one-word answer.
Sure.
Dr. Ashit Shah, what would you do?
Total knee, because of the obese patient, I want to put a stem probably in the tibia, which I can't do in uni.
One-word answer, Dr. Abhishek.
I would go for a partial knee, for sure.
Miten?
Total.
Total knee. Because of mucoid or because of obesity?
Both.
Both. We went ahead and did a bilateral unicompartmental Oxford arthroplasty. What we do is we go ahead and debulk the posterior lateral bundle of the PCL. Anterior posterior stability of the knee is given by the anteromedial bundle. We selectively debulk the posterior lateral bundle. We've published this study of 400 patients, 200 in which we did this procedure and in 200 in which we did not do this procedure in knee surgery and related research, and we found excellent outcomes. So what we do is we go ahead and debulk the ACL. We do an MRI in such patients who complain of rest pain. Any particular comments on this study or this technique, Adarsh?
I haven't seen it being done. I don't know.
It's an original study, sir.
It's a great idea. I do that as well.
Because we are arthroscopic surgeons,
yeah,
we
so
know.
in fact, I use the arthroscopic shaver. It allows you to only look at that particular side that's blown up and remove that effectively. It's very difficult
because
to do
the
that
rest
with
pain is
a
because the
knife.
posterior lateral bundle is impinging between the condyles, and we remove that, and we've seen that there is no instability in the knee after that as well.
Right.
This is last case. This patient was operated by me, 60-year-old male, underwent a bilateral UKR. Patient was fine for 6 months. He went for a hiking trip. Post the hiking trip, he comes to me in this particular fashion with a lot of pain, swelling, unable to walk on the right side. We did an MRI which showed an effusion. We did the blood works to see for infection, no evidence of any infection. We did an aspiration. We got a 100 cc of blood. It was a complete hemarthrosis. Patient was fine after aspiration, had a repeat episode in 2 weeks. No evidence of infection clinically or hematologically. What do we do now?
I'd like to see the other MRI films. What about the components on the MRI? Is there no issue? Also, the MRI would give us information if he's had like a subtle patella subluxation episode.
So the MRI shows only effusion, and it was reported by a musculoskeletal radiologist. and there are no
Probably
other
couldn't
positive
pick up
findings.
much because of the metal artifact, I guess.
And we have a fresh X-ray.
there is-
So these are the post-op X-rays. You can see the clips.
Yes, these are the post-op X-rays. We did fresh X-rays, similar, there was no change, sir.
No change.
So I'd wait. I'd be conservative. Maybe repeat the aspiration
Dr.
because
Adarsh?
it's hemarthrosis.
I really don't know why he has it. I can't tell the reason. If the X-ray is exactly fine, I wouldn't.
So we,
think of any reason.
because of repeated hemarthrosis, we wanted to find out what was bleeding inside. We did an MR angiogram. We got to the conclusion that it's a pseudoaneurysm of the lateral geniculate artery. We referred our patient to our interventional radiologist. He went and embolized the patient. Post 1 year, we published our study in Journal of Case Reports of Orthopedics. And the patient is fine post, even now, 1.5 years down the line. So
It could happen in TKR also.
it could
I
happen
guess.
in TKR. It has been reported in TKR actually, but in UKR, when you're opening the medial side, you're not
lateral
even
side.
touching the lateral compartment. You can still have this due to acute trauma or, no reason at all.
Quite strange.
Yeah, we open the forum for questions for the panelists. If anybody has any questions in the audience.
Can I just make a comment before questions
please.
come? So you mentioned about you would prefer not to do a uni on one side and TKR on one side. I have a series of around 10 patients now. I just feel every knee is different, regardless of which patient it belongs to. So there are a few times when I've done that, and they're definitely more happy with the uni side.
Yeah, so I've done that as well. In my initial years, I used to do more total knees. When I started doing partials, then I offered the same patient partial knees on the other side, and I have a series of patients as well. But I didn't want to do it, for this particular patient because of other reasons
So
as
in
well.
fact, it is better to do it that way. When a patient comes to you with severe grade 4 osteoarthritis in one side, patient says, now doctor, what about the other side? It should not progress to this severe arthritis. That's where I offer them, if they fit into the criteria, TKR on one side, UKR on the other side, at the same sitting.
Unfortunately, we have to close the session. We can just take one more question, sir. Yes.
Yeah, I'm Dr. Shetty from Mumbai. My question is to all the panelists. If you have a patient who has presented with bilateral knee pain, willing for a surgery, one side it's AMO and the other side is an advanced arthritis, how will you approach? Whether you'll do an UKR or a TKR, one side, or bilateral TKR?
I just answered that a minute ago, a
Same.
second ago.
Uni on AMOI
Uni
side,
on one side,
TKR
and
on
then TKR on the other
tricompartment.
side.
Unless it's inflammatory arthritis.
So basically, we had in advance, had attended an advanced course, and we had a discussion on this. This is a very complex question because this is how you convince your patient. If you do a UKR on one side and a TKR on the other side, you are giving a patient a better outcome for his two individualistic knees because all 5 fingers are not the same. However, if you are giving a different approach, so if the patient understands that my both knees are going to function differently, I think that would be an option. But if you think that this patient may come and crib to you, I think it's better to go ahead with bilateral total knee replacements. But I think we can't have a single rule for all patients in this scenario.
Thank you.
We'll have to close the session. I would thank all the panelists and thank the audience for a patient listening.